There is a difference between selling wigs and serving medical clients. One requires product knowledge, the other requires clinical judgment, documentation, and an understanding of what a compromised scalp can safely tolerate. Here are 15 things every medical wig and cranial prosthesis provider should know. Number one, your coding has to match the payer, not the internet. Many plans separate medically necessary hair replacement from a cosmetic wig, but the terminology, codes, and covered diagnoses vary by plan. Code A9282 reads simply as wig, any type, each. It does not distinguish custom from ready made or human hair from synthetic. Some pairs recognize S8095 instead. Verify the accepted code with the client's plan before you prepare anything. Then keep the prescription, the diagnosis code, the invoice, and your provider information consistent. A mismatch between what was prescribed, supplied, and billed is what delays payment. Number two, Medicare generally does not cover this. Original Medicare does not cover wigs or cranial prostheses under the current durable medical equipment benefit. Some Medicare Advantage plans may, and that depends on the plan. Legislation to change this was reintroduced in Congress in February of 2026. It remains at the committee stage. It is not law. Tell your clients that plainly before they spend. Number three, know the tax pathway. Publication 502 allows the cost of a wig as a medical expense when it is purchased on a physician's advice for the mental health of a patient who has lost all of their hair from disease. That language is narrower than most providers realize. Whether it produces any benefit depends on the client's own tax situation, which belongs to their tax professional. Our job is accurate records and receipts. Number four, a lace wig is not automatically a medical cranial prosthesis. In our classification framework, those foundations are industrial grade hair systems. They are built primarily for cosmetic realism, durability, attachment performance, and production efficiency. The concern is not that they are synthetic. The concern is how the construction behaves against fragile tissue. Stiffness, friction, seam architecture, heat and moisture held against the skin, pressure concentrated in one place. A product does not become medical because it is hand-tied, glueless, prescribed, reimbursed, or worn by someone with cancer. Number five, assess the scalp before you touch a tape measure. Radiation fields, surgical sites, scarring, and immune suppression change what can safely sit on a head and for how long. We observe, we document, we refer. We do not diagnose. And if you see active inflammation, open lesions, drainage, unexplained pain, or anything changing quickly, stop the fitting until that client has been medically evaluated. Number six, adhesive is a risk decision, not a habit. Acrylates and methacrylates in wig adhesives are recognized contact allergens, with documented cases of dermatitis along the hairline. Follow the manufacturer's testing instructions when testing is appropriate. A client with prior reactions, fragile skin, or a complex history should be referred for proper dermatologic patch testing, not tested casually in your chair. And understand that bands, silicone integration, and vacuum systems are not automatically safer. Each one brings its own pressure, friction, or traction. Some scalps tolerate none of them. Number seven, measure the scalp, not the hair. Hair adds circumference and gives you a number that will be wrong the day it falls out. Part the client's hair down to the scalp along each measuring line and lay your tape directly on the exposed part. That reading sits much closer to the true post-loss measurement. Then record your method and record the intended wearing condition. A direct scalp prosthesis, a unit worn over retained hair, and a unit worn with a liner do not occupy the same space. Number eight, the head you measured is not the head you will fit. Steroids, weight change, fluid retention, and regrowth all move circumference during treatment. Build in adjustability. Schedule the refit. Number nine, consult early while their own hair is still there. That is your one chance to document natural color, density, texture, hairline, growth pattern, and head shape. Molding is a separate decision. Hair can interfere with an accurate mold, so that step may be better timed later. Number 10, never promise that the hair will come back. Chemotherapy hair loss is often temporary, but persistent and incomplete regrowth is documented, and the numbers vary widely by regimen and by how persistence is defined. A randomized trial published in 2024 found persistent alopecia at 6 months in 52% of participants who did not use scalp cooling, compared with about 13% of those who did. Explain that regrowth patterns differ. A client who is told her hair will definitely return may have to grieve that loss a second time. Number 11, treat the emotional weight as clinical information. The research is clear. Higher alopecia distress tracks with poorer body image and lower emotional and social functioning. Fear of hair loss can even shape how patients feel about their treatment options. What we make may support a person through medical treatment. Number 12. Hair characteristics change the conversation. Scalp cooling results vary with regimen, protocol, cap fit, and the hair itself. A client who cooled and kept partial coverage needs a different solution than one who lost everything. And matching texture and color for textured hair and deeper skin tones takes a practitioner who was trained to do it. Number 13. Slipping is a safety issue, not a comfort complaint. Fear of a unit moving in public keeps people home. Teach retention at handover, band adjustment, stay placement, wearing directly against the scalp, what to do on a hot day. A soft, clean, well-fitted liner can reduce friction and absorb perspiration for a sensitive scalp. It also changes circumference, heat, and retention, so fit it as part of the system, not as an afterthought. Number 14. Hygiene protects a client whose immune system may not. Some treatment regimens increase vulnerability to infection. Clean and disinfect your tools, blocks, and surfaces between clients using procedures suited to those materials. Launder liners on a schedule. And never reissue a worn unit without completing your documented cleaning and disinfection process. Number 15. Document like a lab, whether you build or sell. If you manufacture, your file holds materials, base type, hair origin, processing history, measurements and method, fitting notes, adhesive lot numbers, cleaning records, and photographs at every stage. If you sell rather than build, that record still belongs to you. Get the facts from the manufacturer. Country of origin, foundation materials by name, hair type and processing, cap construction, lot number. Any wear limitations the maker specifies? Keep the specification sheet with the client file. If a supplier cannot or will not tell you what a product is made of, treat that as information about whether to stock it. Selling does not remove your responsibility to know what you supplied, document what you did, and respond when a client reports a concern. Everything we just covered rests on one thing: the foundation. That is why we wrote the Science of Wig Foundations, part of the Hair and Wig Science series. It takes providers through foundation materials, construction, scalp contact, and how to select the right build for the client in front of you so that what you deliver matches what that person's scalp can actually tolerate. If you fit medical clients, this is the reference that keeps you from guessing. You can find it at hairlineillusions.com/books.